Hey, Dr. Shelly.
Hi, Dr. Shelly.
How you doing?
How are you guys doing today?
Well,
Doing well.
I've got the
Great.
tissue out, so
I know. Tissues out.
but I'm good. How are you? Is your evening going well?
I can't complain. I can't complain. The storm has passed over, so we're
That's
doing
good.
good.
It hasn't hit here yet. I'm in Noivus, so
We had a huge,
well, I
like a
know
huge thunder.
we have a doctor friend in common with Dr. Toomer, who was on episode 8, part 1 and 2. We had a good old time.
Yeah.
And we're very excited that you're here with us. You got to hear Mandy's story. We have some questions that are aligned with that. So we're going to kind of just go through them and have a conversation. Sound good?
Sounds excellent.
Okay, great. So for those who don't know you, can you tell us a little bit about yourself, about your career and things you focus on?
Oh, yeah. So I am a board certified internal medicine, obesity medicine physician. So I do a combination of primary care and obesity medicine in Douglasville, Georgia, which is outside of
We're neighbors.
Sorry, I didn't know you were in Georgia. I totally know Douglasville.
Yeah, that's what I was like. You're talking about storms.
The storm, yeah.
Storms too. And I was like, oh, we're in the same place.
We're the neighbors.
But and so I actually have suffered, not necessarily suffered, but I struggled with my weight. I really since childhood. I look at pictures and I see where I was not only the tallest child, but also I had extra weight. I had more weight than the other children did. And of course, kids being kids, bullied and picked on and all the things throughout childhood. It wasn't until I think I got to college when I actually, they talk about gaining the freshman 15. I gained the freshman 25. And it wasn't until I started to actually toward the end, we moved off campus. I was able to cook for myself and started getting active and lost weight. But then medical school happened. And so with the stress, eating on the go, studying crazy hours, that weight started picking back up. And so by the time I ended up finishing residency, I was at my highest weight. And at this time, they didn't really have GLP-1s. They had phentermine, which I tried. Contrave was coming out. I tried. I was working out with a trainer 3 times a week, going to Weight Watchers, Judy Craig to help with the eating. And it just wasn't enough for me. It wasn't enough. After about a year or so, my weight was even higher. Maybe the stress of being a new primary care doc out here, trying to learn, having that learning curve, trying to learn how to, they teach you how to care for people, but it's different when you're outside in the real world. And so where you have constraints and paperwork and admin stuff, all that business that you may not see at your doctor's office, but all the things you have to do. And so at that moment, I, underwent bariatric surgery in 2015. And at my highest weight, I was 285. I was able to lose down to about 205 after bariatric surgery. But then stress happened again. I started gaining that weight back. And before you knew it, I was at 240 or 245. And I knew I had to do something different. I mean, I was still exercising. I was running. I was, still being active. But I realized I needed extra help. And that's when I was started on Saxenda. And if people are not familiar with Saxenda, it was the first kind of GLP-1 weight loss medication. And it was a once daily injection. And so I started doing that and I was able to lose weight. And then I still got back down that 205, could never break that 200 area. Got down, I think, 205 was probably the lowest. And then gained the weight back again. I had taken birth control, and birth control pills just kind of what just happened? But then wegovy started to come out, and that's once weekly injection or semaglutide. And so with that, I also embarked. I started. Let me just talk about this. I started running in 2016, so just a year after my bariatric surgery, after a friend encouraged me to do a 5K and just fell in love with it. So it was one way how I stayed in shape, because I was constantly trying to, go for this race or that race. And so in 2021 is when Wegovy started. And so I also decided to do an Ironman. So a combination of an Ironman training,
Oh my
having
goodness.
Wegovy on board, it allowed me to kind of break that 200 mark. And so
Mhm.
now I'm around like 187, 185, depending on the day. And
Yeah.
so it has been very helpful and being able to get past that point. But it's necessary. And so sometimes, people feel like taking a medication is cheating.
Yeah.
But this is just a tool. This is just, it's like similar to
Right.
diabetes or high blood pressure. You need
Yeah.
a tool to kind of help with getting you to a better place. And so that's how I see the medications. This is more of a tool. So, and that's a little bit of my story. I'm so glad to be on
Yeah.
with you ladies and to
Yeah,
share.
we're so glad to have you on. You're a member
I
of the
know.
community and one of our
Yes,
supporters. So we
exactly.
just
That's
love
pretty
that.
awesome.
Doctor aversion. That's what I was thinking. Okay. So Mandy mentioned that, like, obviously going through a traumatic experience, like
Mhm.
with the doctor that she went to. And also mentioning like when she was young and coming up from a very religious background, like, all those things. I think that being doctor averse seems to be very, very common in our community. Like I've even noticed it with, and I do the same thing. And I very strongly believe that you should work with your doctor, but I still do it. And but I think that it's like we'll go to our community and ask them questions because we're afraid if we tell our doctor, they'll take us off the medicine that's finally working for us, or we don't trust them somehow. Like because for so long, many doctors, because they didn't really know the answer to obesity, right? They kind of knew it was this thing, and we've learned through this show that there wasn't always an obesity specialist specialty, that it's actually pretty new, right? In terms of medical new, right? And I think that it's something that seems to be everywhere. We're afraid, even the doctors that are helping us, it's like we're afraid to talk to them about things. And we tend to go to our community first, and I'm wondering, like, especially since you've gone through something similar before dealing with obesity growing up, why do you think that is? Or do you even feel it? I'm curious.
Oh, so yes, yes. So studies have actually shown that there is a lot of weight bias and weight stigma in the healthcare community. And so it's understandable that people feel this way because it's there.
Mhm.
You may go into a room and the doctor is like, "Oh, you have knee pain. It's because of your weight."
Yeah.
People are like, "Oh, you have back pain. It's because of your weight. Oh, because this is because of your weight." And
Yeah.
so a lot of times when people, I'm a primary care as well. So when they come to me and they're like, I know it's part of my weight. Like this, I
Yeah.
don't know anything about their weight,
Right.
but this is what just comes up, you know?
Yeah.
And they do see it. Sometimes they polled nurses, they polled doctors, and they notice that there is a bias that people who have extra weight, they feel like they're lazy or they're not working hard enough to lose the weight. And
Yeah.
what we know and what we're trying to dispel that notion
Yeah.
among our own medical providers and primary care is that
Mhm.
obesity is a chronic disease. It's not just, oh, eat less and move more.
Yeah.
Like it's not, there's more to it. And when we look at Mandy's story, and I hope you don't mind just sharing some things that kind of help with increasing your weight. But she
Yeah.
mentioned she had suffered with PCOS,
Yeah.
polycystic ovarian syndrome, which makes it very difficult for you to lose weight. It also puts you at increased risk of insulin resistance. And when that means that you have so much insulin in your body floating around,
Mhm.
and too much insulin can lead to more fat deposits that kind of increase your weight.
Yeah.
She mentioned struggling with depression. Our mood plays a role. Chronic stress can lead to increased weight, increases our cortisol
Mhm.
levels. And then on top of that, if you have she didn't say this part, but if you have like a thyroid condition or
Mhm.
even genetics, if it runs in the family, for
Yeah.
me, my family, it runs in the family. Usually like with my mom and my grandmother, they gained weight after having kids. My mom had thyroid disease too, so it increased her weight. But then for me, it was like when I was a child, I had that problem. And
Me
so
too.
so sometimes it runs in the family. And we don't
Mhm.
know everything that we could know about genetics. We do know some things about, some genetic disorders that kind of put us at increased risk for weight gain.
Mhm.
But there's so much more that we need to learn. And
Yeah.
so when the doctors come in, and like you mentioned, it's a new field. So it's not like we were taught this in medical school. I had to actually go in and study and actually take a test to be certified or a diplomat of the American Board of Obesity Medicine. But I learned that outside of residency, outside of that.
Wow.
And so now we're trying to change that so that we can be able, because obesity just affects everything. It affects many different conditions, like over 270 medical conditions that are affected because of having obesity. And so we're trying to teach the generation that's below us, more about what obesity really is and how we can actually approach our patients about it. Because I've had patients that came to me and they're like, "Doc, I don't want to see my gynecologist for a pap smear. I want you to do my pap smear," because of how they felt when they
Yeah.
went to the doctor. They felt like, "Oh, my weight is too much," and it starts from the waiting room. It starts
Yeah.
from, we don't have like a seat for you to sit down, and you're kind of stuffed, and it has what is it called? You know what I'm
Arms.
talking
The
about? The
armrest.
arms.
Yeah.
Yeah.
Pushing your thighs. And then
Yes.
on top of that, you get on the scale and only goes up to a certain amount. So you're like, you already feel defeated just from the waiting room and the scale. And then not only you get to the exam room and we give you a gown that is not big enough to cover you. So you're, let's say if I'm doing an EKG, your breasts are hanging out. So there are many ways where we as a medical society need to improve as far as how we can how we can help people to not feel doctor averse starting from the waiting room. And so I know that's something that we're trying to do, just as a whole obesity medicine, to just teach others so that they can be more aware.
Yeah, I think that's really important.
20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Dr. Shelly, Mandy talked about being pre-diabetic at 19. Even with her weight gain, she, didn't hit the threshold of diabetes, which, A1C is 6.5. So why do some people develop diabetes with obesity and some don't?
So, definitely a couple of things. Mandy did also have PCOS. And with that polycystic ovarian syndrome, it actually puts you at increased risk of insulin resistance. And so what insulin resistance is, and let me just kind of just describe it. When we
That'd be
eat
great.
food,
Thank you.
our body actually breaks
thank
it down into sugar. And so in order for that sugar to go through the bloodstream to like the different hearts, the organs, the muscles to be used for energy, it needs insulin. Insulin is kind of like the key that opens the door so that the blood sugar can come in and be utilized. And people who have insulin resistance, although their pancreas is secreting lots and lots of insulin, it's not, the key is not fitting in that door. So it's basically that sugar is just staying in the bloodstream and just accumulating and accumulating. And so eventually it'll get to the point where the body will just stop responding altogether to the insulin, and that person can develop diabetes. Now, everyone's different in their body because also we have genetics, we have family hereditary, what runs in the family. And so some families tend to just have, even if they're thin, tend to have an increased risk of that insulin resistance, and that they eventually can develop diabetes down the line. However, I've seen, and I will say this, just because it runs in the family doesn't mean you're going to get it, unless you really have to watch what you're eating, making sure that you're having a more low carb diet and physically active just to kind of maintain it. But so just because it runs in the family doesn't mean you're going to get it. But just because you have obesity doesn't mean you're going to get it either. In Mandy's case, she had PCOS that kind of, not only does she have obesity, but then she has PCOS that kind of puts her at increased risk for pre-diabetes. And she had PCOS even when she was younger too. So, that's probably why the case. Now, I know she had mentioned toward the end of her story that she did develop diabetes when at the end, and she's still managing that. The great thing is she's on Mounjaro, and she's lost 133 pounds,
Yeah.
34 pounds, excuse me. So, even though she may have that insulin resistance with the PCOS, it's helping, and
Clearly.
her A1C is probably really, really great now. But
Yeah.
for people with obesity, I have patients who are 300 pounds, and they have no insulin resistance. They have no prediabetes, and it's just more, in that case, more genetics.
Yeah. Yeah. That makes sense.
Wow.
There is I was at a conference and they talked about this. There's a difference between being, you can be healthy fat and you can be unhealthy thin, because there's a difference in how the fat actually gets deposited in the body. Sometimes when you have obesity, you can get fat that's deposited in what we call the subcutaneous layer, which is right under the skin. So it's just kind of staying right there. And then you can have fat that surrounds the organs, like it can surround the heart, surround the liver, surround I'm sorry, I'm thinking. Oh yeah, a lot of other organs. Sorry,
The organs. We understand. Yeah, the organs.
There. But that's when you have like a fatty liver, because all that fat's being surrounded by the organs, and that's what we describe as visceral fat. When people have fat that's surrounded around the organs, it's actually not it makes you more unhealthy, because now with that fat that's kind of clogging the organs, it's not working as well. People, like, for example, people who have a fatty liver, they tend to have higher liver enzymes because of that extra fat. Whereas in cases for other people that or healthy fat, where although they do have a layer of fat, you weigh them, they have a heavier weight. The fat is being deposited in a different way. So it's not causing the unhealthy medical complications because of where the fat is being deposited.
Why is the stomach area an area that holds the most weight even after fat loss? And it's like, I call it like a kangaroo pouch. It's like everywhere else has lost, but you still have your stomach area, your abdomen area that may come down to the middle of your thigh, or like me, where it just protrudes out, no matter what I do.
So
no matter what I do.
So the reason being is it is definitely hormones. So as women, and I don't know how old you are, Janine, because you look young. So please don't get offended. You're 50. Okay. All right.
I'm 50.
So,
Thank you, though.
I'll be honest with you, I wasn't going to say 50. So,
I wouldn't either.
But that's good. It's a good sign. But the reason is, and this actually happens to all women, as we start to enter into that perimenopausal, menopausal phase, our estrogen levels start to change. So we start to get, our estrogen levels usually start to decrease. And when our estrogen levels decrease, our body changes. When we were younger, our body was preparing us for childbirth. So a lot of the fat that was being deposited was on our hips and our booty, kind of in that area. We had kind of that apple shape. But then as we start to enter that perimenopausal, that estrogen level starts to decrease. And so we start, and it's just natural. Now it's getting into our midsection, where it's like, man, this thing is not going anywhere. And so it's really in our midsection and our thighs, upper thighs. And this is why we see increased heart disease in women after in postmenopausal range, because now instead of that fat going to our thighs to help with childbirth, it's going into our midsection, and it's putting us at risk for heart disease. But it's just literally hormones. It's just the estrogen level. And actually, even if a person who has obesity, they do experience that. But then you also see it in women in general, who may be thin and noticing that, I'm getting a little, like you said, your kangaroo pouch, or the medical terminology is a pannus, where it's just this extra hangover, which you didn't have before.
Oh, wow. It's a real thing, Journey.
Okay. Yeah, because
it's like got a name.
I thought that it was just me. And I'm like, wait a minute. And I mean, even people that are on Mounjaro, women that are on Mounjaro or on a GLP-1, they're losing, but it's still like the
Yeah,
midsection is just extremely inflated.
And
And
it's gonna be the
I
last.
just have a very
Yeah,
inquisitive
it's
mind.
last one.
It's the
Yeah.
last thing that's gonna go, unfortunately.
Yeah. Jeez.
Look
Mine's
at
getting smaller. I'll take it.
it's getting smaller. It's getting smaller, but it's like the
We're
last
all in the
thing.
front now. So
Mine is getting there.
Mhm.
Mine
Yeah.
is getting there, but it's not quite there. And you and also Kim and Kat, I was talking to Kim about this earlier. While we're on that, I've noticed that if a person is obese, many times they have hyperpigmentation right here in the cheek area. Why is that?
So when someone has obesity, they're at an increased risk of prediabetes, insulin resistance. And there is a condition called acanthus nigricans. And it's basically a hyperpigmentation or a darkness. It can be around the neck. You can see it behind somebody's neck here. You can also see it in their face. You see it a lot with African Americans who have darker skin, because you can really tell that hyperpigmentation, and it's basically the acanthus nigricans, which is basically another sign of insulin resistance and prediabetes.
interesting. I have that too.
Food has definitely been a very dominant voice in my head. That's not the main focus anymore. Dieting, exercising, and adding GLP-1s through Row is a game changer. I have such a sense of mental freedom since I started with Row. Food no longer controls my thoughts. Family time used to revolve around food, and now it revolves around what we're gonna go do together.
I got a question for you about how American foods contribute to our diet. I was just in it was the Rosie episode, South of France. No.
South of France. It's a hard
Anyway,
one.
but I was just in Nice, France, and the Mediterranean diet was fantastic. I ate a lot, but we had a lot of vegetables, of course, and but a crap ton of olive oil, honestly, yeah, and lots of wine and cheese. But I really only gained like 2 pounds, I think, of water weight. That's what I'm sticking to it. But what is different about the foods in the U.S. versus other countries that they seem to struggle less with the disease of obesity? I will say one on the sidebar: they smoke a lot.
They do.
They smoke a lot.
They're
And I
going
was
down
telling
in
my
some way.
husband, I was like, maybe they smoke instead of eating. But anyway, all right, back to you.
And we'll say something. There is a difference in how they grow their vegetables in Europe. There's a difference in how they prepare their food. And I want to say their food is probably less processed because they are, I mean, they're right there by the Mediterranean Sea. So they do have access to just higher quality of fruits and vegetables. And then I will also put a plug and decrease of stress. So they do have a different mentality. I mean, if you,
super good point.
yeah, I mean,
Yeah.
people are protesting because they went up on the retirement age from 62 to 64, 2 years. And here in America, we're trying to work to the end. I have patients who are 70. I have one lady, she's like, I'm turning 80 and I think I'm going to stop working now. And I'm like,
Oh, wow.
oh, okay, just at 80, huh? so we have a tendency to go, and we're very stressed out. And like I said before, chronic stress can lead to weight gain. But then also, I would say how they prepare the food, less processed, less hormones than what we do here in America. Because, in America, we're trying to bring to the table or to the supermarket food that looks great, that's impeccable.
Yeah.
That doesn't have a blemish, that actually tastes great, and that's in a good stable, and that it will last. And so in order to do that, we sometimes have to put a lot more hormones in it. And sometimes these hormones can contribute to weight gain. I have to say too, the other thing about the Mediterranean diet, they do have yes, they have meat, but it's less meat, but higher on lean fish, lean chicken, like these things that, like you mentioned, lots of fruits and vegetables, a lot of that. Olive oil is a lot better sometimes than your vegetable oil, and definitely a lot better than lard. I mean, we're from the South here, so
Right.
It's
Tallow,
called Crisco.
beef tallow, right? Yeah.
Exactly. Yes. So all the things that aren't necessarily as healthy for you, they don't have it, and they do a lot more walking.
Yes, a lot of
In
walking.
Europe, like I remember. I mean, I when I was in college, I did a year abroad, and it was you would see older persons in their 60s and 70s going for a walk, just like going for a walk. I was in Spain, so they had like a siesta, which I was like, this is great. We all need a nap. But it's just a different way of life, is how I would say it. Like
I get it. Yeah.
they really,
Yeah.
they take a whole month off. Like it's just normal. Like the month of, I don't think it was August or July.
Yeah.
Okay, we're all on vacation. Come back next month.
They do that in Australia too. It's
It
crazy.
makes a difference. It makes
Well,
a
we are
difference.
workaholics
It
in the
does.
US. Yeah.
But I
Oh,
think also it's really just how they process the vegetables and the foods. And then, honestly, I'll just say one other thing. They did a study looking at processed foods, and they noted that when people ate like more processed foods, even if it was like a hamburger, French fries, stuff like that, they tended to actually gain weight. And then when they switched the diet and gave them less processed foods, they started to lose the weight. So it really makes a difference, the processed foods that we eat. And then we
Yeah.
eat more of it here in America.
okay, that makes
Yeah.
sense. I have another question from our community. Kate Jenkins 7. Kate Jenkins 7 on TikTok. She gave me a question for our next podcast, and she wants to know if, with long-term side effects on GLP-1s, basically in short for her, am I going to be on Miralax for the rest of my life? Right. Like, does,
Be okay
you
for
know,
it.
like when you're like, say it's a legit worry, like if you're in maintenance or if you're taking it,
Sure.
long term, are is there
Oh,
really
you got
girl,
your magnesium
that stuff
citrate
is
right
no
there.
joke. Oh girl, you better be close to home.
Karina's showing a magnesium
Yeah.
citrate bottle for those who are
Yeah.
listening who can't see.
Whew.
Yeah.
But
So
yeah,
that's a good question. Will I
Always
always
prepared.
experience constipation?
yeah.
And the answer is so your body can change. Usually with the long-term effects, and it just depends on the person. Some people are able, their body gets used to it and it's less, but it still may be there. Other ways that we do it is that we try to change. Like if you're experiencing more constipation, we sometimes would change it where we're adding more fiber. Where I know for me, constipation was really big before. Oh, yeah, fiber. Well, I would eat like a
Karina has all the things.
prunes at the
Yeah.
it was like dried prunes at the grocery store, and I would just eat one a day, and it just kind of helped me to naturally have that normal movement. And then also I would increase my fiber, put in like some chia seeds, put in
Oh
some
yeah.
flax seeds in the food, just to kind of help. And then naturally, I would sometimes put some little bit of fiber in my yogurt so it would dissolve and I couldn't taste it. And so by increasing my fiber, it really helped. The one thing I would say, a plug for fiber, is that I noticed just personally that as Americans, we don't really eat a lot of fiber. Like even though we may eat salads only has like 4 grams of fiber in it.
Yeah.
And so what I find is that to really have a normal movement, you need around 20 milligrams. So
That's a
you
lot.
may have to work a little. It's a lot. It's a lot. You may have to work a little bit harder and kind of getting that in so that you can
Yeah.
have a normal bowel movement. But if you've been on the GLP-1s and your side effect is constipation, it may be there as long as you're taking the medication. But there are some ways you can kind of naturally tweak it so that you can be able to have more of a movement and it's not forever.
Yeah.
Yeah.
Kale always works for me.